In occupational therapy, often one of the first areas that are addressed is feeding with a patient. If a patient's unable to independently feed themselves, then often we'll modify the task by providing special equipment, which may include built-up handles if a patient has a poor grip, or maybe a weighted utensil to decrease a tremor. Often a divided plate with maybe a contrasting colors would help with vision and help with scooping items. And cups are often used in all kinds of varieties with lidded cups or handled cups. All different types of cups are available. A very common piece of adaptive equipment used in a skilled nursing facility is a reacher. A reacher has multiple uses. It can range from a patient who's had a total shoulder replacement and has limited movement to get things up from the top of their closet, or it could be used, for instance, a patient who's had a recent hip surgery and has hip precautions, and they drop their pills on the floor and they can get their pills and things up. Two other pieces of equipment that are commonly used in the skilled nursing facility that go along with using the reacher with a total hip replacement would be a long-handled shoehorn and a sock aid. Again, precautions do not allow a patient to bend more than 90 degrees, so they can no longer touch their feet or bend to the floor. So in order to get to their feet, they use the two pieces of equipment to take their shoes and socks off and on. The shoehorn just allows a shoe to come up over the heel easily. A sock aid is stabilized. The sock is put over the aid. It's slowly dropped to the floor. Patient places their foot in and pulls slowly until the sock is on their foot. Then they often will just be able to slip their foot into the shoe, use the shoehorn to finish sliding over the heel, and usually their shoelaces have been replaced with elastic shoelaces where they don't have to worry about tying. Another piece of equipment used is a button hook. The button hook has two purposes generally. One side allows a patient who has decreased fine motor skills and limited use of buttoning small areas to slip the wired end through the hole, grasp the button, and pull the button through. The other side has a little pull that they can grab, zipper pulls to help pull zippers up and down. Another area in occupational therapy that's often addressed is positioning. Positioning, generally upper extremity, for contracture prevention and to minimize skin-on-skin contact so that there's less chance for breakdown. Often you'll see a patient who is a fairly new stroke patient or a head injury that has a lot of tone, and you'll see hands in tight fist and a lot of abnormal positioning, and so generally the occupational therapist will either fabricate or measure and order an appropriate orthotic. The orthotic then is kind of tested, and once a schedule is established, then the restorative nurses resume the activity and carry out the schedule, and splints are applied by slipping the hand in, pulling the Velcro straps, loosely fitting the Velcro straps over. Once they're all positioned, you tighten the straps so that you just have a room to slip one finger through each strap. Things you should watch for are that you should check a splint about 15 minutes after application and make sure that there's no signs of any increased pressure, any swelling, red areas. If a red area occurs after a splint has been removed, you should notify the nurse, and it should be checked within 15 to 20 minutes. And if the red spot is still there, the area should be marked and the therapist should be notified.